Hello everyone, welcome to our module on the complications of thalassemia. Before that, just to recap what we have learned so far. As we have learned in the previous modules, thalassemia is a heterogeneous group of genetic disorder with defective synthesis of one or more globin chains. In Malaysia, the most common types are the alpha and beta thalassemia. While untreated thalassemia major patients die during the first few years of life, patients may survive until 4th to 5th decades through regular transfusions programs, appropriate chelation therapy, and effective treatments of complications. In this module of thalassemia complication, we will discuss according to the body systems involved. In transfusion-dependent thalassemia patients, complications usually begin to appear after first decade and increase with age. Individuals affected might ask, if I have thalassemia, how does it affect my body? Which part of my organs will be affected? First, we will look at the endocrine complications. The frequency of blood transfusion will also increase the risk of iron loading in the body. This will affect the pituitary gland, thyroid gland, adrenal gland, pancreas, ovary, and testicles. Growth failure and short stature in thalassemia is due to multifactorial reasons. Hypothyroidism, delayed sexual maturation, zinc deficiency, and low hemoglobins are among the listed risks. Prevalence of short stature varies from 31 to 64%. Short stature is more prevalent in those above the age of 10. Delayed puberty is the complete lack of pubertal development in girls by the age of 13 years and in boys by the age of 14 years. Hypogonadism is defined in boys as the absence of testicular enlargement and in girls as the absence of breast development by the age of 16 years old. In thalassemia patients, delayed puberty and hypogonadism is associated with failure of adequate bone mineralization and achievement of peak bone mass. The prevalence of hypogonadism was noted in 59% of patients who reach pubertal age. Primary hypothyroidism. The majority of patients have primary thyroid dysfunction. Secondary hypothyroidism caused by iron damage to the pituitary gland is rare. Incidence of primary hypothyroid varies from 6 to 51% and increases. There are no obvious clinical signs and symptoms of hypothyroidism despite abnormal thyroid function. Diabetes mellitus is a chronic disease characterized by elevated blood glucose level. It is believed in thalassemic individuals this happens due to the damage of pancreatic beta cell caused by iron overload. Diabetes in thalassemia patients may be due to a combination of insulin resistance and insulin deficiency. The prevalence of diabetes ranges from 10% to 19%, with mean age at diagnosis between 17 to 18 years. Hypoadrenalism may be underdiagnosed and can potentially cause mortality during acute illnesses. Prevalence of hypoadrenalism varies widely from 0 to 45%. So, there is a need to have an annual estimation of basal cortisol level in patients who are more than 10 years old, especially those with wasting. Osteoporosis, defined as a decrease in bone mineral content resulting in weak bones and pathological fractures. 61.3% of thalassemia patients had low bone mass density. Vitamin D and zinc deficiency is also related to osteoporosis among these patients. Hypoparathyroidism. Majority of thalassemia patients with hypoparathyroidism have no clinical symptoms of hypocalcemia. Therefore, annual screening is suggested from age of 10 years onwards.